We're going to call the meeting to order, and if you'll join me in the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Dee, if you could call the roll, please.
Director Nicholson.
Present.
Director Stewart.
Present.
Director Wallace.
Present.
Director Danielson.
Present.
Director Eapen.
Great. Thank you. We have an education session. Nancy,
My pleasure.
can you introduce the speaker?
Yes, the speakers.
Okay.
Every year we celebrate Veterans Day on November 11th. It's a date that's set aside to celebrate and honor those who've served our country. At Washington Hospital Healthcare System, we're very proud to carry on this tradition by recognizing those members of the Washington family who have served in the armed forces. These men and women are veterans, active duty service members, guardsmen, and reservists. Their service and sacrifice to keep our country safe and free. These men and women represent over 70 people within the Washington Hospital Healthcare System who work for our hospital currently and are members of our medical staff or are employed in the Washington Township Medical Foundation, the Surgery Center, Outpatient Rehab, or Medical Billing Unit. It's my pleasure this evening to introduce you to a few of our veterans who are part of the Washington Hospital family. I invited them to join us today to talk about their service and the impact that their military service has had in their lives and careers. First, I'm pleased to introduce you to Michael Plotzbacher. Michael's been with Washington Hospital for over 25 years. He is a registered nurse with a bachelor's degree in nursing and is a certified emergency nurse. He is in the process of pursuing his master's degree in nursing and is slated to graduate in June of 2018. This year, Michael was promoted to the Assistant Chief Nursing Officer position with oversight of the Emergency Department, Critical Care, Intermediate Care, and the Emergency Department Observation Unit. He was previously the nurse manager for the Emergency Department and the ED Observation Unit. Michael served in the Navy for 5 years and achieved the rank of Petty Officer Second Class. I'd like to have Michael come to the microphone.
First of all, I'd like to thank CEO Nancy Farber, the board, the community, and the hospital for the opportunity to speak about my service. I joined the Navy at 17, and what I think it gave me as far as my role in the hospital, I was a typical rudderless 17-year-old, and it gave me a sense of purpose. It instilled personal accountability, and especially relevant to our hospital setting, it gave me a unity of teamwork, and it's not such an egocentric focus. It's all about a goal, an achievement of goal, and how you get there as a group. I do think it's important. I would be remiss as a veteran if I didn't speak to the difference between service and sacrifice. I served. I don't particularly feel like I sacrificed. And I think Abraham Lincoln really eloquently stated it at the end of the Civil War to both Civil War veterans of the families of the Civil War veterans for both the South and the North, that the sacrifice upon the altar of freedom is something that we need to remember everlasting, and I think that's really the key for Veterans Day.
Our next speaker is Harold Smith, who's also a member of our nursing team. We asked Harold to come to tonight's board meeting to tell you about his service to our country. Harold is in his 16th year as the manager of 3 West at Washington Hospital. He's been practicing as a registered nurse for the last 48 years. He served as a hospital corpsman in the Navy from 1962 to 1966. Using his military training, Harold pursued a career in the health field and pursued nursing. Harold?
Thank you. Again, the same as Michael, I would like to thank the board and the hospital for giving me the opportunity to be recognized tonight as a veteran and for the hospital to recognize veterans. I guess one of the things that's interesting to me, when I started in the service, the views of the world were so different then, And I worked with people who had been veterans in the Second World War that were still on active duty when I went into service. So they had a different perception of the world and how we serve and what we do as a country compared to today. I think I had the opportunity to grow as a person because, again, like Michael said, I was a young guy, 20 years old. I didn't know what I wanted to do. I got out of high school, went to junior college, and nothing here and there. And then all of a sudden, I went in the service, and they said, fine, you're a corpsman. So I did that, and I started getting all these good grades, and everything seemed to click and everything. So it really made a difference and became an exciting challenge for me. I think when I finished my time in the service, I had an opportunity to go to work for a steel industry, which was in the Baltimore area, because at that time they hired a lot of ex-Navy guys who had been Second World War corpsmen. And so they offered me an opportunity to grow in that field. And then I went back to school to get my RN. To give you an idea where nursing is today compared to when I got a federal grant as a minority person in a mostly female profession back in the late 1960s, early 70s, compared to today. And on top of my federal grant as my GI Bill. So that was something that was kind of unique. So the opportunities to grow and be able to help other people has been an exciting thing for me in my career. And as I part and think about these things, when I started, everybody had their ashtrays on the table in front of them, and everybody was smoking during the report and everything. So we've come a long way in healthcare since then. So thank you very much for recognizing me tonight.
Thank you, Harold. Next, it's my pleasure to introduce you to Vida Reed. Vida is the program coordinator of the diabetes services at Washington Hospital. She obtained her Bachelor of Science in Nursing from George Mason University. She's also a certified diabetes educator. She has 22 years of experience as a nurse and has helped people with diabetes in the med-surgical units. She has conducted research and led inpatient and outpatient diabetes education programs. She is a member of the American Association of Diabetes Educators and the American Diabetes Association. She serves as a program auditor for the American Diabetes Association. She's been with Washington Hospital since July of 2006. Prior to becoming a nurse, she served 10 years in the United States Army, where she attained the rank of sergeant. Vida?
Thank you very much, Nancy. Thank you all for giving me the opportunity to talk about my experience in the Army. Like everybody else, I was pretty young. I was 18 years old, right out of high school. I graduated from high school and I wanted so much to go to college, but I lacked the resources and the support to do so. So the Army was presented as an opportunity to get funds for college, so I thought, why not? My girlfriend was going, so I thought I'd go too. So I joined the Army and I spent 10 years there. During that time, I grew up a lot, I learned a lot. I started going to college at my very first duty station. I met a lady there, and her name was Mrs. Justice, and I told her, I says, well, I really wanted to go to college, but I joined the Army. And she says, well, you can go to college too. And so I started taking classes. Over the course of my 10 years in the Army, I probably went to 10 different colleges to get my nursing degree. And in the Army, I was a chaplain's assistant. And as a chaplain's assistant, you support the administrative and spiritual growth of a church. And so that's what I did in the Army for 10 years. One of my chaplains actually said to me, why don't you go to nursing school? And I thought, really? I could go to nursing school? And I started to check it out. And at that point, I did change directions and started taking coursework toward going to nursing school. I had a lot of support in the Army for getting my coursework done. And around towards the end of my career in the Army was the first Gulf War. And there was the opportunity that I would, go to serve in that war, and I was going to nursing school, and I wanted so much to finish that. And at that time, it was very scary for people in the military, what would happen during that war and after that. And so I made the decision to get out of the Army and pursue nursing school full time. The Army paid for my nursing degree. I had no student loans when I graduated from college, so I was very fortunate to do that. And far as my experience in the Army and how it helps me today as a nurse, I learned, like Michael said, about teamwork. I learned about professionalism and commitment and all of those things that are very important. I was very proud to serve in the Army. I was really surprised when you guys did the Pledge of Allegiance tonight. I hadn't heard that in a very long time, so it was really nice to hear that. Do you guys do that all the time? Oh, that's very nice. I was glad to hear that. So thank you very much. I appreciate the opportunity to work at Washington Hospital, and I am so grateful for the recognition you guys are giving us.
And now I want to introduce you to Dan Nardoni, a member of our finance team. Dan graduated from California State University, East Bay, receiving his bachelor's degree in business administration with an emphasis in accounting in 1991. In August of 2013, Dan received his master's of business administration and healthcare administration from the University of California, Irvine. In 2000, Dan joined Washington Hospital as a senior accountant. After 5 years in that position, he was promoted to budget manager. In 2009, he took on additional responsibilities as the Director of Budgeting and Ancillary Financial Services, and in 2011 was made a Senior Director in the same role. Currently, Dan serves as the Assistant Chief Financial Officer for Washington Township Medical Foundation. Dan served our country in the U.S. Navy for 7 years. He achieved the rank of Petty Officer, 2nd class. Dan?
Thank you. And thank you all for the opportunity to speak in front of you. As my colleagues have spoken before, I think we had very similar outcomes as far as what we gained from our service, but with different ways to get there. During my 7 years that I spent in the Navy, my job was as an anti-submarine warfare operator and a search and rescue swimmer. My office was the back of a Sikorsky Sea King helicopter with a 500-foot dipping sonar attached to it. So we use that to do our anti-submarine warfare. These are also the same style of helicopters that are used today for the President of the United States flies around in, same style helicopter. We also jumped out of the helicopter with wetsuits into the ocean to try and save and rescue downed pilots and civilians. This was really my first venture into healthcare. As part of our training, and this was to learn how to perform CPR while floating in the ocean. So anyway, during my 7 years, I went on what we called cruises to the Mediterranean Sea, the Baltic Sea, and the eastern coast of South America. These weren't quite the same as the Princess cruises today, as we had 5,000 men on the USS Eisenhower for 7 months at a time. It was, however, the adventure they had promised when I joined. During this time, I was able to find and track submarines in the Mediterranean Sea, and also took part in a successful rescue of a diver off the coast of Florida who had the bends. While in the Mediterranean Sea, my team was also part of a rescue of a jet pilot flying an A-7, which was a single-engine jet. The experience confirmed my belief that flying in a single-engine aircraft was not a great idea. All of that aside, the Navy was really a great place for me to get started, as my colleagues have mentioned. It taught me how to be accountable to others and myself, to be responsible for the things that I did, and how to work with a team, and about leadership. From boot camp through my entire time in the Navy, teamwork was essential. As Michael had mentioned, everything was about teamwork, whether we were getting the aircraft off the ground or loading torpedoes on the side. It was all about teamwork and getting the job done. During that time, I worked with several different commanders whose leadership styles varied dramatically, and helped me really form my own leadership style. After 3 years in the Navy, I realized that as much as I enjoyed being a search and rescue swimmer and a submarine hunter, there wasn't much call for those skills outside of the military. So with the support of my squadron officers in the Navy, I was able to complete all but one semester of my bachelor's degree in business administration with an emphasis in accounting from Cal State Hayward, but before being honorably discharged. Upon leaving the Navy and finishing my last semester of school, I started working in accounting with Arthur Anderson, and that's really where I got into the healthcare industry. It was at that point, doing tax returns. Actually, one of my clients was Washington Hospital. I've been working in healthcare now for 25 years, as it's really an industry with a mission that I'm proud to support. I've been here at Washington now for about 17 and a half years, supporting the patient-first ethic. But I always look back at the leadership skills, the work ethic, the ability to collaborate with others, along with many friendships that I developed during my time in the Navy, is a great foundation that has served me well in my personal life and professional career. I wouldn't trade them for anything. I want to thank all the men and women who have served the military for their sacrifice and commitment.
I want to thank each of our speakers today for sharing their personal perspective about the service. I also thank them for the dozens of other veterans working at Washington Hospital Healthcare System who are not here tonight, for choosing Washington Hospital. At Washington Hospital, we know that hiring men and women who've served in our military or continue to serve in our military adds talented professionals to the Washington Hospital Healthcare System family. And we are proud to be able to have experienced men and women who have served our military. Additionally, I want to remind you that Washington Hospital has a leave policy that allows members of our armed forces or National Guard to be granted military leave from work for the period required when called to active duty for training, inactive duty training, or active duty. Our military leave program allows servicemen and women who choose to continue their military service to be able to do that without fear of not having a job when they return, and without facing financial burdens that are often created when leaving non-military jobs to serve our country. Finally, to honor the sacrifice and service of Washington Hospital employees who have served our country, we installed a commemorative Veterans Wall last year here in Washington West, just down the hall from these auditoriums. The wall has the names, the military branch, rank, and length of service of hospital employees, physicians on our medical staff, employees of the Medical Foundation, Washington Outpatient Surgery Center, the Outpatient Rehab Center, and Washington Billing. This year, we updated the wall with 5 new members of the Washington family who've served our country. I invite you all to stop by and take a look at the updated Washington Hospital Veterans Wall. No matter what branch our military men and women served in, whether in peace or in war, whatever their job path or how many years were served, military men and women commit themselves to service. Their bravery and selflessness is valued and respected at Washington Hospital Healthcare System, and it is that commitment to service that guides our support of our military personnel and veterans. We greatly appreciate the sacrifices made by Washington Hospital Healthcare System men and women who have served our country at home and abroad. We thank each of them for their selfless dedication to our country, and we want to thank them all.
Thank you, Nancy. I'd like to thank Michael, Harold, Vida, and Don for their comments. Service is not limited to the employees. I know we have a board member here who served, and
Next
so
to a veteran.
yeah. So, did you want to make any comments, Mike?
I can just say that after graduating from college, I went into the Army and served roughly 2 years in Okinawa during the Vietnam War. And my experience there totally changed my life. I realized that college was pretty much just a fun 4 years for me. And when I came back, I was a changed person, really a man and really ready to take on an adult job. And so it's really true that what was said tonight, it really changes you for the better and makes you a more responsible person. And I know it did in my case. So.
Thank you for your service.
Sure.
Thank you. Thank you very much. Any other comments from board members?
I just want to say thank you to everyone that was here tonight, and thank you to all of the staff that is not here tonight, but is represented in the hospital. And I think it's safe to say that we're all very, very proud of you. Thank you.
Thanks. Okay, we're going to move on to consideration of the minutes from October 11, 23, and 25.
So moved, Mr. President.
Do we have a second?
Second.
Second from Director Danielson. Dee, if you could call the roll.
Director Nicholson,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Danielson,
Aye.
Director Eapen.
Great. Minutes are approved. Dee, do we have any oral communications?
No, we do not.
No cards. Okay. And then at this point, we'll move on to written communications, the credentialing action items from Dr. Choi.
Good evening. Here to present the proposed credential action items. There are 6 new applicants to the medical staff. The first is Jennifer Areola. She's a perfusionist. Sanaz Kian, reproductive endocrinology and infertility OBGYN. Tang Lee, cardiovascular surgery. Amy Shah, ophthalmology. Kelsey Smith, internal medicine. And Sybil Zachariah, emergency medicine. Temporary privileges have been approved for the following, while the application is waiting for board approval for Dr. Tang Lee. There are no locum tenens. Reappointments, 2-year, include the following: Dr. Balakrishnan of cardiology, Dr. William Busby, emergency medicine, Dr. Harman Chawla, infectious disease, Dr. Joan Chen, anesthesiology, Dr. William Degoni, general surgery, Dr. David Gorzlowski, dermatology, Dr. Scott Kramer, gynecology, Dr. Amal Mahal, gastroenterology, Dr. William Paik, teleradiology, Dr. Seeman Siddiq, internal medicine, Dr. Saif Siddiqui, telemedicine, and Dr. Philip Young, internal medicine hospitalist. 1-year reappointments include the following: Dr. Ahuja, internal medicine, Dr. David Chang, hematology oncology internal medicine, Dr. William Clausen, pain management, Dr. John Yako, pathology, Dr. Warren Johnson, DPM, podiatry, Dr. Marco Pavesi, internal medicine, Dr. Marilee Schuhart, pain management. There are no conditional reappointments. Non-reappointments deemed to have resigned include Dr. Gufran Syed, emergency medicine, and Dr. Michael Tran of pediatric cardiology. Transfer in staff category include Dr. Wendy Su, critical care medicine, from provisional active to active, Patricia Lee of critical care medicine, from provisional active to active, and Dr. Anil Nair, anesthesiology, provisional active to active. Completion of proctoring and advancement in staff category include Dr. Carmen Akawili in hospital and palliative care to active, and Dr. Wendy Su, critical care medicine, provisional active to active. Addition of physician supervisor to Chelsea Joshi is Dr. Alvarez of radiology. Completion of proctoring prior to eligibility for advancement in staff category includes Suzanne Dupler of anesthesiology, Patricia Lee, critical care medicine, Anil Nair, anesthesiology, Mylene Nguyen, perfusionist, and Nabil Shafi, cardiology. Extension of proctorship provisional category includes John Araujo, PA, Kyungmi Kim, pediatric cardiology, Nazhat Soleimani, OBGYN, and Jordan Ziegler, neurointerventional radiology. New privilege requests include Dr. Shazad Ahmad for critical care intensivist, moderate sedation, Dr. Francisco Brun, critical care intensivist, moderate sedation, and Dr. Nabil Shafi, cardiology with CCU level 1, 2, and assisted surgery privileges. Deleting privileges requests include Dr. Balakrishnan for catheter ablation, Dr. Joan Chen for TEE and CEU levels 1, 2, and 3, William Degoni for moderate sedation, and Dr. Marilee Schuhart for implantable devices, and Dr. Nabil Shafi for PT carotid angioplasty, stenting, and thrombolysis. A leave of absence has been granted or requested of Eric Cohen, OBGYN, from 12/1 to 3/31/2018. Resignations include Dr. Joseph Andreessen of anesthesiology, Ramiro Garcia, internal medicine hospitalist, Fabar Medecker, internal medicine, Donna McMillian, pediatrics, Ava Novotny, PA, Meena Tandon, pathology, Aiko Walther, Internal Medicine. Iram Zubair, OBGYN. That's the end of my report.
Thank you very much, Dr. Choi. I'd entertain a motion for approval of the credentialing action items as presented by Dr. Choi.
So moved.
We have a motion by Director Wallace. Do we have a second?
Second.
Second from Director Stewart. Dee, if you could call the roll.
Director Nicholson,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Danielson,
Aye.
Director Eapen.
Thank you. Motion passes. Tim, your action items are approved. Thank you. Oh, Service League report.
Good evening, everyone. First of all, I wanted to let you know that our nominating committee has come up with a new slate of officers for next year, and I'm proud to present as our first, as president. It still has to go to the membership, but for president, they're proposing for the slate of office is Jeannie Yee. Jeannie's been our past president about 4 years ago, I believe. And our first VP will be Ruth Maganta. I hope I said her name right. Ruth is actually retired from the hospital, longtime employee, so I think that's going to be a wonderful addition as well. Second VP will be Jim Santos. Jim is actually one of our newer volunteers as well, and he's working on the Nurse Assist unit, and he's just doing a marvelous job. I think he's going to be a great addition to the Service League in this capacity. Secretary will be Diane Zorzinski, who Diane has been many times on the board, as well as she has served as my scholarship chair for the last 3 years and agreed to do it next year, which is wonderful, as well as Vida did. Treasurer will be Sydney Margolis. Sydney has accepted this again the treasurer is a 2-year term, and your parliamentary will be Umwa. So I'll be there still. So I'm looking forward to working with this team, and I think it'll be really great, and new blood and new energy and places to go and people to see and things to do. The other thing is that the gift shop has been very busy getting ready for our holiday show starting on Monday and Tuesday. The shop will be closed on Saturday and Sunday in order for me to get everything going and ready for everybody on Monday. We also participated in the Think Pink event, Gail and myself. I want to thank Jeannie for her wonderful artwork that she does for us. We received a lot of input on it. This is the 5th year since I started doing this, and I think it's a great way for us to reach out to the ladies as well as men, but mostly ladies, to be honest, and hopefully recruit some. We got a lot of people that were interested. But there was one thing that there was one of the board members really loved, and I have one for her, is... Oh. So could you pass that down to Miss Pat there? Because she's our butterfly of choice. So, yeah, all right, good job. You're welcome. You just never know what's going to happen when I'm around, do you?
We can see that.
So that was a great release, and it's such a great event, and I just feel very passionate about it, I think. And Dr. Degoni did a great job in speaking, as well as our other speakers. The other thing is Top Hat. It was a great honor to be part of Top Hat. I thoroughly enjoyed it. It was absolutely wonderful. And my husband just said, "Have you seen the Tri-City Voice?" And I go, "What do you mean the Tri-City Voice?" No. And he goes, "Give it a Tri-Cities Voice." Well, I got a Tri-Cities Voice, and guess what? I got a picture in there, and he's even in it too. So, but it was a wonderful affair, and I love it. And it's just for such a worthy cause. And next year is going to be a really exciting year. With the anniversary of the hospital in the district, it's going to be, and the new building.
And the new building.
And the new building. So looking forward to that. We have our masquerade jewelry. We're busy. Let me tell you, we're busy. But we have our masquerade jewelry sale coming up, and that's going to be on December 4th, 5th, and 6th. As well as we are going to be having, I want to make sure I do this right, a toy drive. I thought it would be nice last year to kind of do a toy drive, and this is just for anybody around that wants to, has a nice new toy unwrapped that would like to donate it. We are going to accept them at the lobby at the main hospital or in the gift shop, as well as the volunteer services office here at Washington West. I was handing out flyers for the jewelry sale and the toy drive in conjunction at the Think Pink event. So we're just, very busy group, and we're just trying to reach out to our community as much as possible. And this is what I know, a time of year that a lot of people are reaching out. And so if they're able to, it's fine. And but just keep everybody in your thoughts, especially these children that have gone through so much. Our toy drive goes to saves the organization. So I think that pretty much covers it. Been pretty busy. Going to continue to be busy. And we got the Tree of Angels still coming up too, which I'm looking forward to. And we've got a new addition on that this year. We're going to be doing the Niles Parade.
Right.
So that'll be the first time.
That's going to be great.
It's going to be great. So
Great.
thank you.
Thank you so much, Debbie.
You're welcome.
Look forward to more work. Great. We'll move on to our medical staff report. Dr. Choi.
So I'm happy to report that we have 587 members now of the medical staff and 336 active medical staff members.
Can we start with the video, please?
Past health promotions and outreach events. On Thursday, October 19th, Washington Hospital hosted the annual Think Pink Breast Health Awareness event. The event featured a health fair and presentations by Dr. William Degoni, General Surgeon and Medical Director of the Women's Center, Dr. Sunil Upender, Radiologist, Dr. David Lee, Hematologist, Oncologist, and Medical Co-Director of the UCSF Washington Cancer Center, Anjali Rao, breast cancer survivor and Washington Wellness Center yoga instructor, and Kimberly Alvari, registered dietitian. Dr. Victoria Leapart, gynecologist, moderated the event. 359 people attended. On Sunday, October 22nd, Lucy Hernandez, Community Outreach Project Manager, provided information on health-related programs and services during the 5th annual Running Dead 5K, 10K Fun Run and Walk, hosted by Mark Green Sports Center in Union City. More than 100 people visited the health information booth. On Thursday, October 26th, Washington Sports Medicine provided a sports physical clinic for high school student athletes. The physicals were held at Washington High School, and athletes from all local schools in Fremont were invited to participate. Each student received an assessment and physical to ensure they meet the California Interscholastic Federation requirements in order to play sports. Doctors Russell Nord, Michael Golden, Stephen Zahner, and nurse practitioner Sherry Kneebone provided the examinations. Athletes also received orthopedic screenings by certified athletic trainers. 105 students received sports physicals. On Friday, October 27th, Washington Sports Medicine provided athletic trainers and hosted a first aid booth at the Special Olympics soccer event held at Maloney Elementary School in Fremont. 217 student athletes participated in this event. On Saturday, October 28th, Washington Hospital hosted the biannual Children's Health and Safety Fair. This free interactive event provided health and safety information for families. It also featured the popular Teddy Bear Clinic, staffed by the Washington Township Medical Foundation. The Teddy Bear Clinic allowed children to bring their favorite stuffed animal for a checkup. This event was co-sponsored by UCSF Benioff Children's Hospital, Washington Township Medical Foundation, and the Washington Hospital Employee Association. More than 250 people attended. On Wednesday, November 1st, Dr. Victoria Leapart presented Nutrition Myths. 30 people attended. On Friday, November 3rd, Washington Sports Medicine provided athletic trainers and hosted a first aid booth at the Special Olympics soccer event held at American High School in Fremont. More than 300 students attended. On Saturday, November 4th, Washington Hospital hosted the annual Diabetes Awareness Health Fair. The event featured a health fair including blood glucose, cholesterol, and blood pressure screenings, along with diabetic foot exams. Dr. Sangeetha Balakrishnan, cardiologist, presented Heart Health and Diabetes, What is the Connection? And Anna Mazet, registered dietitian and certified diabetes educator, presented Quick Meals on a Budget. 117 people attended. During October and November, Lucy Hernandez presented 20 hand hygiene classes for students at the following elementary schools in Fremont: Harvey Green, Hirsch, Mission San Jose, and Wybell. Lucy also presented at Kennedy and Music Elementary Schools in Newark. Information was provided on proper hand washing and hygiene to prevent infection and the spread of germs. 498 students attended. Upcoming health promotions and community outreach events. On Thursday, November 9th, from 6 to 8 p.m., Dr. Jalruza Mansouri, obstetrician gynecologist, will present Understanding HPV, What You Need to Know. On Thursday, November 16th, from 6 to 8 p.m., Father Jeff Finley, palliative care coordinator, will present Getting Through the Holidays When You Are Grieving. Also on Thursday, November 16th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart will present Mindful Eating for the Holidays. On Saturday, November 18th, from 10 a.m. to 1 p.m., Washington Hospital will host the annual abdominal aortic aneurysm screening. Aneurysms develop over time and may have no symptoms, but if one bursts, it can cause immediate and life-threatening symptoms. Dr. Ash Jain, cardiologist, Dr. Gabriel Herskew, vascular and endovascular surgeon, and Dr. Sarah Wortman, vascular surgeon, will be on hand to interpret results from this Doppler screening. This event is sponsored by Fremont Bank Foundation. To register, call 1-800-963-7070. On Thursday, December 7th, as part of the Diabetes Matters series, Dr. Victoria Leapart, gynecologist, will present Difficult Conversations, Tips on How to Talk to Your Healthcare Provider. The Washington Hospital Healthcare Foundation Report. The Washington Hospital Healthcare Foundation hosted the 31st Annual Top Hat Gala on October 14th in the tent at Washington West. The evening began with a hosted cocktail reception, followed by dinner and dancing. 630 attendees joined us to raise funds for the Washington Radiation Oncology Center to purchase a new linear accelerator. This treatment modality will increase the hospital's ability to provide advanced radiation therapy to patients right here in our own community. Helen Kennedy, the president of the foundation, said, "The evening was a great success, and I am so grateful to all the sponsors and donors who supported this important cause. My thanks go to this year's gala co-chairs, Gary Charlin, Dr. William Degoni, and Debbie Jackson." Join us on Friday, November 24th at 6 p.m. for the Niles Festival of Lights Parade. The Washington Hospital Healthcare Foundation is this year's presenting sponsor and will be featured on one of the parade floats. The Washington Hospital Healthcare Foundation is preparing for the annual Trees of Angels celebration, which raises funds for hospice and palliative care. Please mark your calendar and be sure to join us at one or more of the following holiday tree lighting events: Bernard and Family McDonald's at the corner of I-680 and Mission Boulevard on Monday, November 27th at 6 p.m. Washington West on Thursday, November 30th at 6 p.m. Newark City Hall on Monday, December 4th at 6:30 p.m. Union City City Hall on Friday, December 8th at 6 p.m. For more information about these events or to inquire about sponsoring Trees of Angels, please call the Foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors Report. Washington Township Healthcare District Board members attended the Ohlone College 50th Anniversary Gala on Saturday, November 4th. Washington Hospital Employee Association, W.H.E.A. W.H.E.A concluded the 2017 Drive for Warmth clothing drive on Friday, November 3rd. 9 barrels of warm clothing items and blankets were collected and delivered to the Tri-City volunteers to be distributed throughout the community. Washington on Wheels, WOW Mobile Health Clinic. During the month of October, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Senior Center and Fremont Family Resource Center. WOW also provided occupational health services including influenza vaccines at G, a medical device company creating mobility enhancement products for physical therapy and athletic training. California Brazing, a manufacturing company focused in heating and thermal management for the development of metal and ceramic parts. Fremont Bank, a retail and commercial bank. Lee's Imperial Welding, a producer of structural metals. Mizuho OSI, a medical device company specializing in surgical tables. And Shockwave Medical, a company working to reshape cardiovascular interventional therapy. These companies are located in Fremont, Hayward, and Livermore. The total number of community members receiving health care from the Washington on Wheels Clinic during the month of October was 352. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The most viewed web pages include Employment, About WHHS, Programs and Services, and Physician Finder. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media post may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of October, Washington Hospital's cable channel 78 InHealth captured new programming, including a Diabetes Matters program called Exercise is Medicine. In addition, InHealth aired a Diabetes Matters program titled Diabetes, Is There an App for That? 2 health and wellness programs called Strategies to Help Lower Your Cholesterol and New to Medicare, What You Need to Know, and the October Board of Directors meeting. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070. And please follow us on Facebook, Twitter, Instagram, and YouTube.
And now it's my pleasure to introduce our November Employee of the Month, Callie Lane. She's an application analyst too, pharmacist, and works in our IT division now. I think she was a little surprised, but her colleagues think she shouldn't have been surprised at all, because her contribution to the success of the W.H.E.A team has been very instrumental in building a safe medication use system. She joined Washington Hospital as a clinical pharmacist in 2011. She started in the emergency department, working with physicians, nurses, and directly with patients. Her presence in the emergency department helped patients get the right medicine in a timely manner. Her transition to the EPIC team meant her analytical skills would be utilized and developed, and she's known for her let's make it happen approach. According to her manager, Vicki Otting, the director of inpatient clinical applications, Callie has a can-do attitude. If there's a problem, she'll take her time, analyze it, and come up with the solution. She was raised in Tennessee, educated in South Carolina, and she completed her residency in Tacoma. When her boyfriend decided to move to Fremont for a job, she came with him. And I think she's glad she did. She has a new career at Washington Hospital, and they've been married now for 11 months. They recently purchased their first home. When not spending time at work or doing home improvement projects, the couple can be found at Warriors games. She's an avid fan and a season ticket holder. When asked what makes her job special, she doesn't hesitate. It's the people. I can't believe how lucky I am to work with such a great team of people whose common goal is to serve patients, directly and indirectly. And I think that fits just perfectly with what we hope for and expect of our employees. And congratulate Callie.
Thank you, Nancy. We'll now move on to our Lean Kaizen report. It looks like we're going to have some more certificates and pins.
Okay. Time for us to step up.
Yes, we have 2 certificates that we're going to be presenting tonight. But I wanted to just start by saying a few words. As we know, we began our Washington Hospital Lean journey in October of 2014. And really, we've been focusing on becoming the high-quality, low-cost provider, and that our journey will help us to achieve that. It's important. We've been working with a consulting group called Verona Consulting, but as we continue down this journey, that we do need to have individuals who are certified with us, who have spent the time to learn the Lean tools, and will be able to continue to promote and teach Lean activities throughout the institution. And again, this is really this process improvement methodology that we work with day in and day out on our operations. So it is a training that takes a 12 to 18 month process, and it requires demonstration of proficiency in the Lean concept and tools. And we, those who've gone through the process are evaluated on our performance. There are a number of requirements. There's a classroom education that's taught, and also then different workshops that everybody who's going through the certification process must participate in, including leading Kaizen workshops and also working as a team lead too. So tonight, I'm very proud to present. We have two, our newest Lean certified individuals. And to date, we've certified 30 individuals. And so why don't I have Dr. Nicholson and Nancy come up, and we will present our two individuals. The first one we'd like to present is Mr. Edward J. Fayen.
Here we go, Ed. Congratulations.
You need to have
in
your
between the two of us, please. There we go. Congratulations.
Congratulations, Mr. Edward Fan. Next, I'd like to introduce to you, our next person is Kathy Weinberg in critical care. Yay.
Here you go, Kathy. Oh, thank you. Thank you.
Congratulations, Kathy.
Thank you.
Sure.
All right, Shree. Thank you. Congratulations.
Congratulations to all of those who've just become Lean certified.
You don't get to sit down for very long. We're going to have our construction report. And I'm sure it's a lean operation.
Thank you, Dr. Nicholson. So we have, I think, a good, continuing good report on the construction front. Things are progressing well on the inside of the building, and we're still on line to meet a substantial completion date in June. As I've talked about in the past, we have the additional projects, which are the loading dock, the connecting corridor on the first floor, and the circulation, which are going to go and be the last projects that are done before we get substantial completion on that. And the final dates on those, we're still working out. We still have the targets in early August. We may go back by that a little bit in terms of those outside projects being completed. I'll talk more about that in a few minutes. So this is a picture that sort of represents the beginning of the work on the new loading dock and connecting basement corridor on the basement of the pavilion. So right here is what was the employee entrance, the back of the current loading dock. This was the utility connection from our central plant project. And this was sort of the last remaining vestiges of the 1956 building back in the yard. So they're taking all this stuff out, and this will be the area that the new corridor will come out of and towards the other building. So that's underway. This just shows you that we're starting to get wire installed in the data room in the basement. These are the pneumatic tube blowers that are located in the basement. The pneumatic tube system ties into the existing hospital system, so we'll be able to move things back and forth between the two buildings. It also is tied to the 2500 building. This gives you, I think, a pretty good shot of the restrooms are getting completed throughout the whole building. And you can see, there's nice tile work going in through the whole place. This gives you a shot of biomed. We've shown this several times. As you can see, that's getting close to a completed space. The elevators are just about functional. They actually are going to be doing testing at the end of this week and hope to get those functional and start using those. And then I think I've mentioned the idea to take the lift down. It's still in operational. As soon as the internal elevators become operational, the lift will come down. We anticipate that in the week to 10 days. This gives you a shot of the ceiling of the main lobby as you walk into the hospital, where the Morris Hyman statue will be, where the atrium is, etc. Here you have a shot of a critical care nursing station, I would say one thing that was interesting in my going up there, that space, we have 5 pods, and it's beautiful space. And it's big enough that I've started to get lost as I go up there, in the current state of things. I mean, they're big pods, and they all are basically identical as you go in and out of them. So I think that's going to be a huge positive addition. This shows you one of the waiting areas. So as you come up the elevator, you walk out into the atrium space, and then these waiting areas are immediately to your right and left. And that's where you wait until you are brought back to one of the critical care spaces to visit your loved one. This is a 3rd floor, just showing that we're starting to get casework moved up to those. This is a patient room that's getting some of the cabinetry. This is the atrium space that doesn't really do it justice. You can see the skylight up in the top in that. One of the aspects of this space on the 2nd and 3rd floor, they have something called wand doors that'll be on the side, and those are, when the fire alarm goes off, those enclose the atrium. So that's one of the aspects of this building that's a little unusual. If you've looked out lately, all the scaffolding is removed from the front of the building, and you can get a much better. They've completed most of the metal panels on the front of this building. The only parts that are still not finished are where the basement corridor connects into the building. So you're getting from the back of our hospital, you can see the front of the new hospital, and you get sort of the completed look of that building. So that's where we are. Okay. Now we have a couple of special things I want to talk about. First, we have a short film or video that's going on InHealth Channel 78 that's narrated by the vascular surgeon John Thomas Mehegan, and it provides you and the community with an update about the construction of Morris Hyman Critical Care Pavilion and key features of the new building.
Hello, I'm John Thomas Mehegan. Welcome to the latest in a series of facility master plan updates that we'll be bringing you to keep you up to date on the latest progress in our hospital construction agenda. As you know, Washington Hospital is in the midst of an ambitious expansion process. In 2004, the Washington Township Healthcare District Board of Directors developed a long-range plan to meet the needs of the fast-growing population in our community. Phase 1 has been completed, and Phase 2 is well underway. It includes the construction of a 7-floor parking garage adjacent to the Morris Hyman Critical Care Pavilion, which will house an expanded, state-of-the-art emergency room and critical care units.
The facility master plan was driven by SB 1953, which was a state law that went into effect that basically mandated that all acute care hospitals in the state of California become compliant with what was then the earthquake standard or seismic standards, and they wanted everybody to become compliant within a certain timeline. And we need to be here for the community in the event of a major quake. You know, the demand for that service is never going to be greater than after a quake.
Named after the late founder of Fremont Bank, entrepreneur and philanthropist Mr. Morris Hyman, the pavilion's ground floor houses mechanical, electrical, and information technology equipment and space for a pharmacy, cafeteria, kitchen, materials management, and storage.
The Morris Hyman Critical Care Pavilion is a expansion of the facility of 250,000 square feet, 4 stories. It will house an expanded ER, almost 3 times the size of our current facility. Our emergency room is the second busiest emergency room in the county. 5,000 patients a month are seen by the facility. We're just busting at the seams.
A new, greatly expanded emergency department occupies the first floor, along with the building lobby and shell space that will be used for clinical care in the future. The second floor provides 48 critical care beds in 5 separate pods, and the third will feature 68 medical surgical beds, all private rooms.
On the parking garage, as part of the overall master facility, we relocated our existing helipad to the top of the parking facility. It enables us to continue with our growth without interfering with our services.
While all of these features make for an impressive facility, it's just as important to note the superb materials and construction methods used to bring the entire project together.
The biggest thing about the Morris Hyman building is that it's a world-class facility, and it starts with the exterior skin. Metal panels are the obvious choice for a building like this. You look at them, they're durable, there's no maintenance to them, they're also insulated. So that now lets you create a very efficient structure where your envelope has a very high R value, which essentially means it doesn't let heat escape the building. So the really unique thing about this project is that the building sits on 72 base isolators.
The base isolated building, basically the base isolators absorb the shock, and therefore the hospital basically remains totally intact and functioning at the end of a major quake.
So these are the base isolators, 72 of them that hold up, that allow the building to move. This accounts for the 3 feet of movement in each direction. Essentially, if you think of this like a giant ball bearing sitting on 2 steel cups, it allows the building to move, come back together, and return back to its original point, what we call 0, 0. Next to it, you can see the viscous dampers. You get a perspective of how big this thing is. The viscous damper is important to the system in the Morris Hyman building. What it does is that absorbs that energy of the earthquake and will help control the rate of movement inside the structure so that in a large event, you will not feel the impact of that seismic event. So this is our moat wall. So this is reinforced shotcrete with a concrete cap on top. Essentially, we dug a pit for the building. You can see the gap up there, that 3 feet puts it in perspective that's how far the building can move. If you're in a hospital, you're either there visiting someone who's had a very unfortunate event, or you yourself have had a very unfortunate life event. It's not a good time. You need to make sure that the last thing you ever want to worry about is the building. You know, the building has to work.
The Hyman Pavilion, as far as the master plan that took place, this is the ultimate piece of it. It's going to increase the capacity of the emergency department so we can see more patients, have adequate space in there, have adequate space for patients, for privacy, improve the infection control, have greater throughput, things like that. Those are all things that we've needed in the current facility.
Interactive TV. The status of the pavilion is it's scheduled substantial completion is June of 2018. We are on track, on time, and on budget at this particular time.
As you can see, Phase 2 of Washington's Facilities Master Plan is right on schedule. We made a special effort to ensure that everything meets or exceeds seismic requirements and allows for expansion required to meet the growing needs of our community now and in the future. We'll be back with updates on the progress of our Facilities Master Plan soon. In the meantime, you can find further information and updates on the master plan on our website. I'm John Thomas Mahegan. Thanks for watching.
Okay, so I would like to just cover one last thing on the action items tonight is a discussion about a budget amendment. And I'd like to just go over that very quickly so that it's clear what that's all about. So all the updates so far that you've seen in the video and that I've talked about have covered the goings-on in the building itself. And we have multiple things that we need to add on to the building to complete it or bring it to final completion. So the first three would be the connection on the first floor of a open air but covered canopy system that takes you from the existing hospital over to the main lobby. That was not included in the original budget. We had simply an open sidewalk. So this is additional work and additional scope. The second one is, unfortunately, as I guess I would say, when we looked at this, one of the things we found right here at that corner of the connection was a sewer line and a sewer point of access. And so to put that in the middle of the public entryway just didn't make any sense. And there is also a storm line there as well. So we have to move those for practical purposes down here to what I usually call the west, but it's actually the south end of the area. So get it out of the public thoroughfare. And then we have added in scope an emergency exit out of the emergency room for what we know will be the eventuality of people needing to get over to the main hospital for emergency surgery and for emergency cath procedures. And have decided that we had plans for that access, but nothing that was going to be as direct as this. And so that is also an added scope to the project. And so those things were not budgeted, not in the construction budget. In addition, we have all the circulation around the site. And to be clear, we had, when the project was bid, there was an allowance for circulation as it was drawn. After we had awarded the contract, there was a reevaluation of the whole circulation at the emergency room because of concerns of not having adequate space for the number of ambulances that we are experiencing now on a regular basis. Not having any stacking capacity there, not having any parking up close, handicap parking or other close to the facility, not having adequate drop-off space right at the emergency area. So all this circulation was reworked, and so that is not, that's more of a redesign of existing scope of project. And then this area that was back in here was not included in the budget. So those are the areas that we're asking for a budget amendment, multiple things that were not in the budget, not in the scope of the project, and then some areas that were redesigned. And so I just wanted to make sure that everybody was clear when you consider that action item. If I can answer any questions.
Any questions? No, thank you very much, Ed. We appreciate the information. Okay, we're going to move on to our quality report, and this is going to be by Mary Bowron for quarter ending September.
Good evening, thank you. I will be going over our quality dashboard for quarter ending September 2017. Starting off with looking at our core measure compliance, we continue to do well with our VTE prevention. Again, this is a bundle of interventions that are done while patients staying admitted at the hospital that can prevent the patient from developing blood clots while they're here. So we have been at 95% compliance for patients who are outside the ICU and about 99% for patients inside the ICU. And this is not a sample, this is all of the patients who meet the criteria from algorithms. So it's a large population of patients, and we've still been able to maintain a high level of compliance there. Moving into stroke, we've had some good outcomes here with process. About 100% of patients were able to get their discharge medications that were appropriate to prevent clots, made sure that all these patients also had stroke education prior to discharge, and were assessed for rehabilitation. We actually only had one patient that was not assessed for rehabilitation, and it was a documentation issue. So overall, we've done well with our stroke core measure compliance. For infection prevention indicators, we continue to look at central line associated bloodstream infections. We did see an uptick here. We had about 3 central line associated bloodstream infections, 1 in critical care, 2 in med surg. This is above the benchmark from the CDC, so infection control is starting to work closely with the shared governance model that we use here so that we can be working with nursing and seeing and making sure that we're sticking to all the hand hygiene that we need to. Are we scrubbing the hub every time we access a line, especially in critical care? These patients are getting their lines accessed a lot. Very sick patients there, so want to look back and make sure that we're following the bundle prevention. So we'll be working closely with them on that. And moving into the catheter-associated urinary tract infections, we did see an increase here, which is the last quarter we had seen quite a bit of a decrease. We did implement the nursing-driven protocol so that we can get these lines out when patients no longer need them for medical necessity. That is driven by nursing with the support of the medical staff. And so we did see this uptick. And Dr. Martin is working closely with us on reviewing those cases to see if we can see a root cause analysis and see what we can do to prevent those further. It's that was actually 2 catheter-associated infections, putting our SIR at 2.1. C. diff continues to be a challenge, but we are holding steady at least at about a 1.3 SIR. And just as a reminder that anything above a 1 is higher than what is expected by the CDC. But we're continuing to meet with the C. diff task force, and really it's just keeping forward with making sure that we're working with antimicrobial stewardship, but we're still working closely with EVS and still making sure that we make hand hygiene compliance a priority here. And we have had the local Alameda County Public Health Department come in, and California Department of Public Health has come in and done validation surveys to see if there's anything we can make improvements on. We do that. We take that any opportunity we get from them. We voluntarily have them come in and do education with us. And one of the last things that they were recommending is really going back and looking to make sure that the samples of stool that you are testing are appropriate for testing. They say because you don't want to be over reporting. So we're looking at that, and Dr. Martin and the infection control team and I are working closely with lab to make sure that we want to validate that process. It's probably our biggest focus right now. With hospital-associated MRSA in the blood, we did not have any of those this last quarter, I'm happy to report. A VRE, we did have one, and actually it was the same patient that had the central line bloodstream infection, unfortunately had VRE, and so that also comes in with doing a root cause analysis on seeing if there's any of the contributing factors that we can find. That puts us slightly above the benchmark from the CDC. Surgical site infections with colons, we did actually have 1 infection, which was just equal to what the CDC expects us to have. So 1 is at the benchmark. You can see we've had quite a bit of success keeping that under the benchmark for numerous quarters, and hope to see that go back down. This was a very sick patient who arrived in circumstances that were, that they had the surgery followed up in critical care, and they do take wound class into consideration, and of course this type of procedure is high risk for getting infected. And like I said before, it's the first one we've had in a while. Abdominal hysterectomy continues to also be at 0, well below the benchmark. Nursing sensitive indicators for hospital-acquired pressure ulcers, otherwise known as bed sores. This is something that we can say we've actually seen a statistically significant decline in, which is good. This is for the last 2 quarters. And in this quarter, 9/17, we actually did a point prevalence where members go in and look at 118 patients in this case to see if there's any pressure ulcers developing or advancing from the way that they were documented before, and we did not see any hospital-associated ulcers. So I went back and worked with the wound team and kind of to see, is there anything they did that was different? And really, I think what it is that the bundled approach is coming together really well with this, rounding on patients frequently, making sure they're repositioned, making sure we're using the most up-to-date products, and wound care nurses rounding. All of this bundle has come together, and this is a result of a good outcome since we've been able to implement the bundled approach really well in these cases. Patients who have had falls and injuries, this is basically still under the benchmark for CalNOC for patients with falls with injuries, but any fall we take seriously here, and we're looking at the use of gait belts and how we use them and when we use them, and par leveling to make sure that there's plenty and that they're always accessible. And so just in general, the ambulation process, because this was a unintended descent to the ground where the patient was just needed extra support, and the injury was not severe. It wasn't a fracture. It was just a bruising to the hip. But again, we look at each one of these, a huddle. There's root cause analysis done. Take each one very seriously. Moving into the Joint Commission National Patient Safety Goals, handoff communication. The Joint Commission expects to see it in about 90% goal, and we're at 99.2, so we are above the benchmark, meaning that when we spot check handoff communication to make sure that all the elements are met when a patient changes a unit or changes staff assignments, it's important to make sure that all that communication occurs on what's going on with the patient's condition, and we've been able to stay above the benchmark and sustain that for quite a while now. Patient identification, again, 100% out of all the ones that were identified under direct observation, all of the 2 patient identification factors were met and documented. So a good compliance there. And procedure timeout, we've always sort of had one that falls out every quarter for the last couple of quarters, and I think they've been doing a lot of education. The cath lab actually deserves to be commended for this. They've done a lot of education to make sure that when your timeout occurs, that you make sure that you hit every box in the electronic medical record and make sure that it's all documented appropriately. And this last quarter, they were able to meet with that, and we measured at 100%. Hand hygiene is something that we'll always continue to be monitoring and working on. It's just always going to be an effort we're going to have to continue to make. We have a compliance rate at 99.1. Joint Commission's national standard is about 90%. What we've been doing in infection control is always what we've been doing in the past, which is training people, making sure that they meet the standards and understand what they're watching for when they go out and observe the staff, physicians, ancillary, everybody here is observed in a clinical setting. And the idea is to rotate new observers so that we don't have too much Hawthorne effect, so that people aren't used to, okay, this person's here to observe hand hygiene. And we've been, just have another group coming out, about 6 people. So I think that'll help. Readmission rates, as you know, we compare to the national CMS readmission rate, and we actually have a downward trend for all areas that we're looking at. To start off with pneumonia, these are patients that come back within 30 days of their initial admission, and our readmission rate for pneumonia was 7.3, so only 3 patients came back out of the 41 patients, and the CMS national benchmark is 16.9. So beneath that, heart failure, which is something that probably the area that we've struggled with most with readmissions, we have had definitely a downward trend now for the 3rd quarter in a row. And 9/17, we had 11 patients come back out of 65. And as I've mentioned here before, it's 11 returns. It's not necessarily 11 different patients. In this case, it was 8 different patients who returned, but the total returns of 11. And that's the way the CMS wants us to measure it. But our benchmark was, we were at 16.9, but the benchmark is 21.6. Moving into AMI, otherwise known as a heart attack, same thing, 5 patients out of 36 came back, and this is actually lower than the CMS national benchmark at 16.3. So when we look at these and we think all 3 of these areas are in a downward trend, and especially heart failure, and we're hoping to continue to see this trend. I do think that we've been sort of shining a light on this, and we've worked with the medical staff, nursing, all the multidisciplinary team is coming together and working, in clinical ops readmissions reduction team is working together, and we've been looking at the data. It's hard to identify one intervention that's working. We're just rolling out new interventions, making making sure that these patients have a good discharge plan prior to leaving the hospital, and that we follow up with them afterwards to see if they have any issues or concerns. We're in the early stages of that, so we don't really know what's been effective and what hasn't. But either way, all three areas are starting to show a decrease. Thank you. Any questions?
Great, thank you very much, Mary. Any questions for Mary? No, good progress in some areas and more work to do in others.
Absolutely.
Yeah,
Yep.
that life
Thank
goes
you.
on. Thank you. Finance, Chris Henry.
Okay, good evening. Tonight we're going to review the operating and financial results for September for Washington Hospital. Starting with our operating indicators, our average daily census for the month was 10.5 over budget at 164.9. We had 1,048 admissions versus a budget of 946, about 11% variance there. Our patient days also were up, 315 more patient days than we expected, at 4,948. That was about a 7% variance. So that all equates to a shorter length of stay. So our average length of stay for the month was shorter, 0.29 below budget at 4.61 days. Our outpatient equivalent observation days were 71 below budget at 143 for the month. Looking at utilization, case mix index for the month, just a little shy of what we expected, pretty close at 1.523. That's an indication of the severity of the cases we had. Deliveries for the month came in at 130, about 18 below the budget of 148. Surgical cases for the month were 34 below budget at 345, and most of that in the outpatient area. Included in that number is our joint replacement cases that were 6 below budget at 128. Our neurosurgical cases were 8 below budget at 20. Our cardiac surgical cases were 3 below budget at 9. However, the cath lab was busy. So cath lab saw 26 more procedures than expected in the month at 367. Outpatient visits, pretty close to budget, 39 above budget at 7,059. And our emergency visits were 86 above budget at 4,309. Quick look at our cath lab activity for the month. Our peripheral vascular and cardiac business flip-flops as to who dominates the business in a particular month. This month it was cardiac at 43% of the activity, followed by peripheral vascular at 34% for September. Looking at productivity, our productive FTEs were 23.5 above the budget at 1,263.8. We had 174.6 non-productive FTEs for the month, giving us total full-time equivalents that were 13.5 above the budget at 1,438.4. However, our FTEs per AOB were in line at 6.59, and that's a good indicator that we had managed to the activity. Moving into the financials. Total patient revenue for the month came in a little over $3.1 million above the budget at $169,518,000. We had a favorable payer mix with lower governmental sponsored patients and pretty good PPO in the month. So we ended up with our contractuals at 75.92% of gross revenue versus the 76.91 that we expected. However, we did see some of that given back in bad debt, and I'll get into that in a minute. So we ended the month with net operating revenue a little over $2.3 million above the budget at $41,295,000. Operating expenses, however, were $2.3 million, almost $2.4 million above budget at $40,776,000. The lion's share of that really coming from our provision for bad debt and charity. Last month, Nancy discussed with you that the percentage of private pay revenue in our payer mix for the month was at 3%. We've been seeing that at 1.8%, so a significant spike there. We also had 5 high dollar accounts hit that provision for bad debt and charity. The 5 accounts had mounted to $1 million all on their own. So we ended up with bad debt about almost $1.3 million above the budget at $4,282,000. I think we're going to continue to see that trend as we move through the year. We've been seeing it for the last 5 months or so, and we're seeing, again, that shift. The reverse of the shift we saw a few years ago when the Medi-Cal expansion came in, we're starting to see that reverse. Also driving that variance, our salaries and wages were above budget with our higher FTEs. We did have higher productive FTEs in the month, about 2%. Benefits were about $360,000 over budget, and we've been seeing higher health and welfare claims this year over the last several months, and that trend also continued into October. So when we look at October next month, we'll see that number. That's really been the driver there. Supplies were below budget by about 8.2%, offsetting that. We also had a pretty high variance in our purchase service and pro fees line. A number of things going on there. First, we had some timing differences. We received a couple of large prior period invoices, one from one of our intensivist groups and one from our security company. So we have prior month expenses hitting this month. We also had higher than expected dialysis fees. We expected to have ended our relationship with W.H.E.A in August. That drug into September, and that drove that number up. We also had some plant maintenance costs. Ed has reviewed with us the removal of that old chimney. There was some asbestos abatement that hit in the month, so all those things really drove that line up. So we ended the month with operating bottom line just a little bit under budget at $519,000. We'd expected $555,000 as we get through these slow months in the summer and fall. Non-operating income for the month came in $652,000 below budget at $1.106 million. That largely driven by a $550,000 unrealized loss on our investments. As the stock market continues to climb, our fixed income securities tend to lose value. So we ended the month with a total bottom line. Again, this is our GASB format, which is the way we produce our numbers for our audits. Governmental Accounting Standards Board presentation. So we end the month with a total bottom line of $1.6 million, about $688,000 below what we expected for the month. Take a quick look at our Financial Accounting Standards Board format, and this is a representation of how FASB entities might, in the financial markets, might adjust our financials to look at them. No changes to the operating bottom line at $519,000. They do pull out our tax revenue that supports the debt service on our general obligation bonds that are helping us build that beautiful building that Ed previewed, and our unrealized loss on investments to come up with non-operating income from a FASB perspective of about $300,000 and a total bottom line of $819,000. So are there any questions on September?
Thank you. Nancy?
We'll go for the preliminary results for October. Our gross revenue was $162.6 million, and this is below budget by 1.8% or $2.9 million. Compared to October a year ago, it was a 3% negative variance. So it's somewhat better than a year ago at this time, but it's still not what we budgeted. Our inpatient gross revenue is about $1.3 million above budget at $120.1 million. Where we fell down was in the outpatient gross revenue, and it was down by $4.2 million. So our major drivers of revenue variance turn out to be surgical volume coming in below budget by 8.2%. And that brings the surgical services revenue down by $2 million. Our cath lab procedures were below budget by 10.4%, or $1.3 million. The inpatient days were above budget by 103 days. The ICU days came in below budget, and that drove revenue from room and board below budget by $357,000. The higher inpatient days drove ancillary services revenue above budget by $900,000. So it's kind of up, down, all over the place. In terms of our key census statistics, our average length of stay was 4.68, and that's below budget by the budget of 5.03. And our average length of stay was 16th of a hundredth days higher than October a year ago. Our outpatient observation days were 57 below budget. Our outpatient observation days were 95 below budget. Wait a minute, I think inpatient and outpatient are transposed here. Inpatient observation days are 57% below budget. No, I'm sorry, I'm getting this confused. I apologize. The outpatient observation days are 57 below budget. Compared to a year ago, they are 95 below October of 2016. Our average daily census of 154.1 was above budget by 2.2%. So we have more admissions, but a shorter length of stay. Admissions of 1,035 were above budget by 106. Compared to a year ago, they're 12.4% higher. Patient days of 4,777 came in above budget by 103, 9.1% higher than a year ago. The surgical cases in October were 337 below budget. Now, inpatient surgeries came in just 4 cases above budget. Where we fell down was in the outpatient surgeries, and we were lacking 34 cases. General surgical cases were below budget by 33. Cardiac surgeries down by 5. Neurosurgical cases above budget by 4. Joint replacement surgeries were also above budget by 4. In the cath lab, we had 313 procedures, and they were 25 below budget. And compared to October a year ago, they were 36 below. Inpatient cath lab procedures of 145 were spot on budget. Where we fell down, once again, is in the outpatient arena, and we were below budget by 25 cases. In terms of the division of labor in the cath lab, the cardiac procedures were below budget by 16 and below last year's volume by 34. Neurointerventional radiology procedures were below budget by 6. Non-vascular interventional radiology procedures were below budget by 2, and peripheral vascular procedures were below budget by 1. Deliveries also came in below budget by 5. And they were 7 deliveries below October a year ago. Non-emergency outpatient visits of 7,741 were above budget by 759. That's a positive variance of 10.9%. And they were above October a year ago by 14.4%. The lab visits were above budget by 506. Cardiac rehab visits were above budget by 152. Lymphedema clinic visits were above budget by 96. That's a lot for that small clinic. Infusion center visits were above budget by 64. Prenatal diagnostic center visits were 53 below budget at 105. We are still awaiting approval to open that clinic, although it appears that Ed and Robert may have cornered W.H.E.A and state licensing into actually taking an affirmative step. We're hopeful. But they are limited to 3 days a week when we had budgeted them at 5 days a week, and we've been waiting since March in the last fiscal year to get this open. The emergency room visits of 4,362 were 46 below budget, and above budget, above volumes a year ago by 24. In terms of our preliminary productivity indicators, our FTEs came in above budget by 19. That's a 1.5% variance at 1,250.9. Non-productive FTEs came in below budget by 3.1. Total FTEs of 1,411 were above budget by 15.9, or a 1.1% variance. Our total FTEs per adjusted occupied bed of 6.76 were above budget by 0.12. That's a 1.8% variance. In terms of our other operational statistics, our outpatient surgery center had 487 cases in October. That's 24 above budget. Clinic visits came in above budget at 4,079 for the month of October. Washington Urgent Care was below budget by 58. The Nakamura Clinic came in at 155 visits above budget. The Newark Clinic was 99 under. The Warm Springs Clinic was above budget by 69, and the Ohlone Clinic down by 34. Now, the payer mix is certainly important because it drives the bottom line, perhaps most of all. And our preliminary information indicates the government-sponsored patient revenue made up 71.6% of our total gross revenue, which was just 0.1% above the budget. HMO revenue was 3.5% of gross revenue. We had budgeted it at 3.0. PPO revenue came in at 22.7% of gross revenue, and we had budgeted it at 23.7%. Private pay revenue was 2.2% of gross revenue. We had budgeted it at 1.8, so you can see this continuing trend that Chris was talking about earlier in his report. And finally, days cash on hand in October ended at 186 days, up 2 days from the prior month. The days of gross revenue and accounts receivable were 54, and this was down from 61 days in the prior month. And there were $677,945 in charity care applications pending or approved in October. So you can see that number is an increasing factor in our operational results.
Nancy, any questions for Nancy on October? If not, we'll move to our action items, which will be presented by Director Danielson. And we have action item A.
Mr. President, I hereby move that the board authorize the Chief Executive Officer proceed with the purchase of hardware, software, and implementation services for the network security upgrade and enhancements in an amount not to exceed $657,194.
Thank you. Do we have a second?
Second.
Second from Director Wallace. Nancy, you want to present?
Data security is a huge issue for the hospital. More and more data is stored electronically, and it's increasingly difficult to block malicious attempts to access and steal health information and personal identity information. So having strong network controls and systems that monitor the network traffic are of paramount importance to us. Our current intrusion prevention solution is no longer supported after April of 2018. And so we need to replace that. Our database that we use helps identify and provide protection against the latest vulnerabilities as they're identified. and we send our data off to SecureWorks each day for review and analysis. So maintaining an up-to-date and active intrusion prevention solution is tremendously important to the hospital and its patients. In addition, enhancing this upgrade with Identity Services Engine ensures all devices connected to our network are validated and adhere to our security policies. So there are lots of reasons for doing this, and I strongly urge the board to vote aye.
I would agree. I don't think you can say the words Yahoo, Target, or Equifax without thinking data security. Any other comments from the board? If not, Dee, would you call the roll?
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Eapen?
Motion passes. Thank you. Item B.
Mr. President, I hereby move that the board authorize the Chief Executive Officer to enter into the necessary contracts and proceed with the purchase of 24 R-Series and 4 X-Series defibrillators for Phase 1 of the defibrillator replacement project for a total amount not to exceed $637,330.
Thank you. Do we have a second?
Second.
Second from Director Wallace. Nancy, would you provide background?
It's time to start replacing our defibrillators in the hospital. The ones that we have now were purchased in the year 2000, and most of our existing defibrillators are at end of life. A multidisciplinary committee investigated all the various vendors and defibrillator options, and this committee was led by L.V. Ballar and included members from the Code Blue Committee, Anesthesia, OR, Cath Lab, the Emergency Department, Critical Care, and the Med-Surg units. And they selected the Zoll system, I guess you can call it. It has all kinds of bells and whistles that are hard for me to explain as a layperson, which I'm sure you understand far better than I.
Yeah, no, it's much better than the old defibrillators. The technology has moved a lot in the last 15 years.
Yes, it has.
Yeah, so
it's time.
Yeah, and it's amazing that those 15 years have gone by that quickly.
Yeah, it is.
Yeah. Thank you very much, Nancy. Any questions from the board? If not, Dee, could you call the roll?
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Eapen?
Thank you. Motion passes. Item C.
Mr. President, I move for adoption of Resolution Number 1183, Budget Amendment for the circulation of Morse-Hyman Critical Care Pavilion site. This will provide additional funding to complete additional scope of work, the redesign of emergency department access and circulation areas, and the redesigned corridor and improved loading dock area for an amount not to exceed $7,154,152, and directs the Chief Executive Officer to execute the contractual documents to complete this project.
Thank you. Do we have a second?
Second.
Second from Director Wallace. Nancy, do you have anything to add to what Ed had told us?
I think Ed explained it.
I think we have a pretty good idea, and hopefully the community does as well. This is a sizable amount. Any questions from the board? Comments?
No.
Okay, Dee, if you could call the roll.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Eapen?
Okay, motion passes. Ed, you can get to work now. Again, item D.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the Chief Executive Officer to enter into the necessary contracts and proceed with the purchase of the ICU Progressa bed in an amount not to exceed $49,894.57.
Thank you. And we have a second from Director Wallace. Nancy, expensive bed, but important.
This is a pretty special bed. We have one. It's 15 years old. And once again, I think we have exacted every ounce of useful life from it. I want to tell you a little bit about what this bed does and how important it is to the critical care unit patients, who many of whom are not especially mobile. This is a budgeted item. It provides percussion and vibration therapy, and this is important to prevent pulmonary complications. Patients in respiratory failure get a lot of help from being in a bed. And it helps loosen secretions and clearing of the bronchial airways and preventing atelectasis. It helps prevent acute respiratory distress syndrome. It has a rotation therapy feature, and the automated rotation of the bed from left to right helps reposition a patient as programmed by the nurse, and this is used to help lung expansion and to prevent pressure ulcers. There's also a feature of advanced microclimate surface mattresses, and this helps prevent pressure ulcers and provides added comfort to patients as it wicks away moisture and heat from a patient. It has a stay-in-place technology, and this helps extend the head section of the frame and surface in unison to accommodate the natural elongation of the body as the patient sits up. It helps so the patient does not slide to the foot of the bed when in the semi-Fowler's position, and it allows less manual work for the nurse, who currently has to lift and pull patients in bed frequently. And so this should help with staff safety. It also has a chair egress position, which helps support our early progressive mobility initiative, helping patients get out of bed.
I like that last one especially, mobilizing our ICU patients quickly. Any questions from the board?
I was wondering if it talked.
You know, Bernie, it just might. It just might. A lot, you know, they're incorporating a lot of voice warnings on some of these items. Dee, if you could call the roll.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Eapen?
Great, motion passes. And item E?
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts and proceed with the purchase of the MISO OSI HANA table in an amount not to exceed $90,700.70.
Thank you. Do we have a second? Second from Director Wallace. Nancy, a new operating table for anterior hips.
Is for the joint replacement program, and it's used for the anterior approach to hip replacements. And it will allow for unique patient positioning that enables the surgeon to replace the hip through a single incision, which is entirely in keeping with our approach of minimally invasive surgery. This is a table that Dr. Saw trained on, and it's his table of choice.
Great. Very good. Thank you, Nancy. Any questions? If not, Dee, could you call the roll?
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Eapen?
Okay, motion passes. Nancy, we have need for a closed session?
Very brief.
Okay, thank you. We're going to adjourn to a closed session at this time. We're going to reconvene the meeting to open session and announce that no reportable action was taken in the closed session, and there being no further business before this board tonight, this meeting is adjourned.